So thanks very much for inviting me today. It's a pleasure to be here. I thought I would spend a little bit of time giving some background on emphysema to discuss the context of lung transplant, and then tell you a little bit about how the lung transplant program works and what some of the issues are around lung transplant. So the logistics here are I have to wave at David when I want to change slides. So I don't have any financial relationships to declare, and I should probably be frank with you and say that I've been asked to speak because of expertise about lung transplantation, not because I have a specific expertise in Alpha-1 antitrypsin. So emphysema, as many of you will know, is a disease where the main finding is destruction of the little walls that go between the air sacs in the lungs, between the alveoli. And over time, this leads to larger air sacs, which might sound like a good thing, but what it means is that there's less surface area for the air and blood to exchange oxygen and carbon dioxide. So the gas exchange in the lung becomes less efficient. Another aspect to this is that with destruction of these walls, you lose elastic tissue, and this results in impaired lung mechanics, because when you blow out, a lot of the movement of air is driven by the elastic tissue in the lungs, and if you lose the elastic tissue, the lungs don't empty as they ought to. So these are the major features of emphysema. Emphysema is overwhelmingly associated with cigarette smoking, but interestingly, it's only a minority of smokers who develop emphysema, even people who smoke for many decades. And there's a lot of interest in knowing why that is, but presumably there is some predisposition in the people who develop emphysema, some difference between them and the people who don't develop it. For quite a while now, it's been known that a particularly strong predisposition to emphysema comes from Alpha-1 antitrypsin deficiency. So as you probably all know, Alpha-1 antitrypsin is an antiprotease that inactivates enzymes that are released by white blood cells. So when white blood cells come into the tissue, they may cause inflammation in the lungs or other organs, and the Alpha-1 antitrypsin is something that helps to contain that inflammation and to limit the tissue damage that results from it. Most, but not all, Alpha-1 antitrypsin is made in the liver. So the general notion is that the Alpha-1 antitrypsin that's working in the lung is getting there through the blood, although some of it is made in the lung itself. Severe Alpha-1 antitrypsin deficiency occurs in people who have 2 mutant copies of the gene. And there are various estimates about the incidence, but one number is 1 in 6,000 or 7,000 North Americans. And this may account for 1% or perhaps more of patients with COPD. COPD is a blanket term for emphysema and chronic bronchitis. So I didn't nod yet, David, but that's okay. So Alpha-1 antitrypsin deficiency is associated with early onset emphysema, and many patients are affected as early as their 30s. In some patients, the emphysema has a distinctive pattern, but certainly not in all of them, and in some cases it's indistinguishable from emphysema occurring in other patients. The typical emphysema we see in smokers is described by pathologists as central lobular emphysema, and the typical distribution is that it's more severe in the upper lobe. So you see where I've drawn the blue arrow here on the left. The darker lung tissue is the more diseased lung tissue, and that's in the upper lobes in this smoker. People with Alpha-1 antitrypsin deficiency tend to develop emphysema that has a different appearance under the microscope that's referred to as panacinar emphysema, and it tends to affect the lung bases more than the upper lungs, although that's not universal. So you see in this CAT scan on the right side, the arrow shows darker, more diseased lung at the bottom of the lung. So what's the medical treatment of emphysema? Well, really the central treatment is to get people to stop smoking, and that is far more important than anything else that can be done for emphysema. Vaccinations for influenza and pneumococcus are important. Bronchodilators and a few other medications are helpful to relieve symptoms, but don't affect the course of the disease. Pulmonary rehabilitation can be extremely useful to improve people's functional status and their quality of life. It doesn't, though, directly affect the lung disease. And supplemental oxygen can help to improve people's functioning and also improve survival when people pass a certain threshold. In Alpha-1 antitrypsin deficiency, there is also the possibility of replacing the deficient enzyme with, as you all know, with augmentation therapy. Thanks, Tim. So what does this consist of? Well, many of you know better than I do, but it consists of weekly infusions of pooled human donor alpha-1 antitrypsin. And it's very clear that you can get blood levels, sustained blood levels of alpha-1 antitrypsin that are above the levels where people usually get emphysema. So, in principle, that ought to be helpful to protect the lungs. There is some evidence that this therapy can help to preserve lung function. But randomized trials have not yet, at least, proven definitively that this affects long-term clinical outcomes in terms of things like hospitalizations, survival, so forth. Next slide. And there are a few reasons for that. It's not a rare disease, but it's relatively uncommon. It progresses gradually over years. The goal of therapy is not to make the disease clear up and go away, it's to stop it from progressing. So that's going to take more time and be harder to show. And the impact of the therapy may be relatively modest, although people argue over that, and I think more data is needed. Next slide, please. There are some surgical options to treat emphysema. One of these is lung volume reduction surgery. And you know how I showed you on the CAT scan that in a lot of patients there's dark, more diseased lung tissue in the upper lobes. Well, if you selectively remove that tissue, you may not harm the gas exchange very much, and there may be some advantages. You may give the better quality lung tissue more room to function. You may also improve the chest mechanics, because when you have emphysema, you lose elastic tissue, the lungs get bigger, and they don't empty well. And the diaphragm, which is supposed to pull down to fill the lungs, may already be pulled down. So if you reduce the volume of the lungs, you may actually improve the mechanics so the air can move in and out with less effort. You have to be quite careful about who you select for lung volume reduction surgery. There are some people where it's clearly harmful. There are other people where it seems to provide quite a consistent benefit. So there are some pretty strict ideas about who's a suitable candidate. There is some data that this is somewhat less effective in alpha-1 antitrypsin deficiency than in other forms of emphysema, with smaller gains in lung function and less sustained gains in lung function. But it's still an option. I was speaking to Tom Waddell, who's a thoracic surgeon at Toronto General who does these operations, and they have done a number of them on alpha-1 patients. So for some patients, it may be an option. Next slide, please. So lung transplantation is really the only definitive therapy for end-stage lung disease, the only therapy that will make the disease go away. And those diseases, the common indications would include emphysema, pulmonary fibrosis, cystic fibrosis, and pulmonary hypertension. After transplant, there's usually a dramatic improvement in respiratory symptoms and lung function and quality of life. That's the good news. Unfortunately, there are a lot of potential complications, and the long-term outcomes are not what anyone would like. And the long-term outcomes are not nearly as good as with some other solid organ transplants, like, say, kidney transplants. Lung transplant, in many ways, is a Canadian success story. As some of you may know, that the first successful lung transplants were done here, and we're still just about the largest and one of the probably the best known lung transplant program in the world. So there's been a great deal of growth in lung transplants over the years. Going back to the 90s, our program was doing about 30 transplants a year. In the last few years, it's been around 100. On this chart, the blue bars are the bilateral lung transplants, so replacement of 2 lungs. For diseases like emphysema, it's possible to do a single lung transplant, taking out 1 diseased lung, putting 1 graft lung in. And the red bars are the heart-lung transplants, of which we do a relatively small number. What are the reasons, the indications for lung transplant? Well, in all programs, the largest number of transplants is done for emphysema, or COPD, which here represents about 1/3 of our almost 1,300 transplants. The second leading indication for transplant would be pulmonary fibrosis, and the third leading reason would be cystic fibrosis. So how does this all work? Well, recipients are usually referred by their respirologist, and there are criteria in terms of lung function, but and usually the people being referred would have an FEV1, the amount you blow out in 1 second, of less than about 25% predicted. But more importantly, people need to have a low or really intolerable quality of life due to their symptoms, or to have recurrent hospitalizations with life-threatening exacerbations. And if people have low lung function, but their quality of life is decent, or they're not having life-threatening episodes, then usually we think they're better off without a transplant. People have to be non-smokers for at least 6 months. And they can't have other major medical problems, although this is something that has really evolved a lot in recent years. It used to be very strict, and now the envelope keeps getting pushed. So it's sort of a moving target as to who is an acceptable candidate. People who have severe heart disease, severe liver disease like cirrhosis, kidney failure, cancer, or who are very overweight, we would probably not list for transplant, but we're certainly happy to discuss individual circumstances with your physician. And the fact that somebody's had a heart problem or a liver problem doesn't mean that they're automatically not a transplant candidate. So when people are referred, we have an initial discussion with them, let them know what they'd be getting into, what some of the issues are, what the outcomes are. And if people want to pursue it further, then we set up a formal assessment. And the goal of that is twofold. One aspect is to assess the lung disease. The other aspect is to identify and plan around any complicating issues, especially things like heart problems or kidney problems, but sometimes there are social circumstances that are difficult or other issues. This generally consists of 4 days of tests and meetings, and usually we do it as an outpatient at Toronto General. After that, all this information is compiled. Each patient is then discussed by the entire transplant team at an assessment meeting, and a decision is made. Some people would be considered to be suitable but too early for transplant. Others would be considered suitable, and we think they should go ahead and be listed. Sometimes there are issues that need to be sorted out. Other times, usually because of other health problems, we don't think the person is a suitable transplant candidate. The other decisions that are made are whether the person can have a double or a single lung transplant. Most often people will be listed for both, and the timing of listing. One issue I should have alluded to before and didn't is that there's no age cutoff for lung transplant. Usually by the time people get to their 70s, there tend to be other health problems that would get in the way, but we've transplanted people in their mid-70s. They have to be in pretty pristine health apart from the lungs, but age itself is not a reason to turn somebody down. Once people are on the waiting list, they're given a pager, and they can get a call any time of day or night to say their lungs available, we need you to get into Toronto General, and the operation usually goes ahead within a few hours. Sometimes people get called in and we only determine that the lungs are not going to be usable, so they get sent home without getting a transplant on that occasion, which is rough for people. Generally, we expect people to relocate to within 2 hours of Toronto, and people come to exercise sessions at Toronto General 3 times per week. The reason for this is to try to have people as strong as possible going into the transplant and give us a chance to get to know people and see what the trajectory is of the lung problem. This obviously creates a lot of difficulties for people who live further away, and we, as techniques of organ preservation have changed, as we may get a little more warning that the lungs are going to be available, we're able to be a little more flexible with this, but we're worried about that because we don't want to not see what's happening with people or not have people exercising. So generally we would want people to come to Toronto for at least a period, and it may be possible to go back home while on the waiting list with regular visits to Toronto, but it's going to depend on the individual circumstances. On average, people wait around 6 months for lungs, but it can be as little as a day, or it can be 2 years. The lungs have to be matched for the body size and blood type, and it's just random what lungs become available and who else is waiting that's a match. Either one or both lungs can be replaced in the transplant operation. It's a very big surgery. People are in the operating room up to 12 hours. Afterwards, everybody goes to the intensive care unit and is on a ventilator, at least for the first 2 days or so. There are lots of tubes, lots of machines, and things are very complicated during that time, and there are lots of potential problems that I won't go into, but generally people can get through that. But it's not unusual to have some setbacks, and there are people who spend quite a while in the ICU after the transplant. Typically, people are in the hospital for 2 to 3 weeks after the operation. After transplant, people need to stay near Toronto for the first 3 months, and this is really essential. There tend to be a lot of adjustments in terms of medicines. There tend to be a lot of little issues. We see people in the clinic every week initially, and we also want to try to build people's strength up again, so they're coming to the treadmill room to exercise with their physiotherapist 3 times a week. Over time, the follow-up becomes less frequent, and after 2 years, we see people only once a year. So really, there's this very intense involvement when people are on the waiting list and post-operatively, and then a lot less as time goes on. People still need to have regular blood tests and breathing tests indefinitely. After a transplant, people need to take usually 3 strong immune-suppressing medicines for life. And usually people are on a number of other medications. And these are very strong drugs, and they've got significant side effects. There are a number of complications of lung transplant that it's worth mentioning. One of them is rejection. What this means is that the immune system, the white blood cells, start to recognize the graft lung as foreign and start to damage it. Sometimes this is quite subtle and the person doesn't have any symptoms. Sometimes it's quite obvious and it's like a pneumonia. We confirm it with a bronchoscopy and we take little biopsies with a bronchoscope. And usually this will respond to giving a big IV dose of steroid, of prednisone. When the immune system is suppressed, as you can imagine, people may be vulnerable to infections. And they can get unusual infections with organisms, especially with certain viruses and fungus and things that aren't usually virulent enough to cause disease in a normal host. But when you suppress the immune system, these things can start to cause problems. We're used to diagnosing those things and treating them, but sometimes these infections can be severe and sometimes they can be fatal. There are other complications that arise in the long term that might not be obvious if you're not familiar with transplant. One of them is the chronic kidney damage, which is a side effect of the immune-suppressing drugs. And we can see this developing, but we can't stop the drugs because then the lung would be rejected. And this results in a significant number of patients eventually needing dialysis. So it's a minority of patients, but it has a big impact on people's quality of life if it happens. There is an increased risk of cancers in people who've had a suppressed immune system for a number of years. We particularly see some particular kind of lymphoma in the first few years, and in the long term see an increased incidence of skin cancer, which may be minor but can sometimes be serious. The biggest long-term complication of lung transplant is something called bronchiolitis obliterans syndrome, which is sort of like chronic rejection of the lungs by the immune system. And unlike the acute rejection that I described before, it's a kind of a gradually progressive thing, and there are some things we do to mitigate it, but ultimately we can't do much to stop it from progressing. So people may wind up a number of years after a transplant with very low lung function again or back on oxygen, which is obviously a huge disappointment. If you look at the overall survival of patients in our program, the numbers are very good if a person's looking at not living another year, but if they may live quite well for the next 5 years, then you certainly don't want a lung transplant. At 1 year, around 81% of patients overall are still alive. At 5 years, around 55%. At 10 years, around 38%. There's a little bit of variation depending on the operation. If you look at the disease, some diseases tend to do a little bit better and others a little bit worse. We find that patients with emphysema tend to have a smoother post-operative course than some of the others. Some of the patients with pulmonary hypertension and pulmonary fibrosis tend to have more difficulties immediately post-op. But over time, the outcomes in emphysema, COPD, which is the green line, are pretty similar to the average. A very important point to make clear is that lung transplant in well-selected patients may improve survival in emphysema, but that is not proven. So we don't think that we should be promoting lung transplant to say that you will live longer with a lung transplant. It is very clear that lung transplant improves lung function and quality of life in emphysema patients, so we think that people should be listed and transplanted on that basis, which is different from things like pulmonary fibrosis, where you can know with near certainty if somebody's not going to be alive in a year based on their condition. It's quite hard to predict that in emphysema, even if a person has very low lung function. So lung transplant has not been proven to prolong average survival. In terms of Alpha-1 antitrypsin deficiency, patients with this diagnosis are overrepresented in the lung transplant population. I was looking at our numbers, and as of a week or two ago, we'd done 1,281 transplants. 352 were done for emphysema, or COPD, and of those, 81 had Alpha-1 antitrypsin deficiency. So that's 6.3% of all the transplants, but it's about almost a quarter of the transplants for people with emphysema. Looking at the International Society of Heart and Lung Transplant has information online where you can look at all the lung transplants that are in the registry for the world. And in the 1990s, Alpha-1 accounted for about 10% of lung transplants, and now it seems it's accounting for a lower proportion, about 3.5%. Mostly that has to do with the Alpha-1 patients being generally younger and having fewer problems than other patients with emphysema, so they were more likely to be acceptable in the past and more likely to be acceptable now. But as programs have relaxed the criteria for having transplants, a lot of older patients with other health problems have become acceptable candidates. Interestingly to me, looking at the ISHLT data, there is actually a small decrease in the total number of transplants being done for Alpha-1 in the last 10 years, down from around 130 a year to around 100 a year. And I don't know the reasons for that. I think smoking rates probably have a lot to do with it. Augmentation therapy, possibly. But it's an interesting observation. There's some papers, like this one from our group from 9 years ago, that suggested outcomes were worse in Alpha-1 patients. This seemed to have to do with increased rate of infections, some increased rate of what we call intra-abdominal sepsis, so complications with infections in the abdomen. Other groups have not necessarily found that. And if we go to the next slide, when I took out the data from the ISHLT website and looked at all the Alpha-1 patients versus all of the emphysema patients, the Alpha-1 patients are the blue line, and the overall emphysema is the red line. And you can see that as you get out past about 3 years, the outcomes seem, if anything, to be a little bit better in the Alpha-1 population. And that would probably reflect this being generally a younger population with fewer other illnesses. One question is, you have this protein that helps to suppress inflammation, and you replace the lungs, but the protein isn't coming from the lungs by and large, it's coming from the liver. So the people who've had a lung transplant still have low levels of alpha-1 antitrypsin in their bodies, and in their lungs. And does this create increased rejection? Does this lead to other problems? If you show the next slide, please. If you look at chronic rejection, Alpha-1 is the blue line, and there doesn't seem to be any difference with the other groups. And we don't have information, although there's potential concerns, we don't have information that that Alpha-1 patients have more complications in terms of rejection post-transplant. So Alpha-1 antitrypsin deficiency is an important cause of emphysema. The emphysema may have unusual features like young age at onset and a pan-acinar pattern with a lower lobe predominance, but it doesn't necessarily have these features, and it can be indistinguishable from other emphysema. The emphysema may be slowed by augmentation therapy, but it's unclear quite how effective that is, and of course the cost is very high. Otherwise, the management of alpha-1 antitrypsin emphysema is the same as for other forms of emphysema, although lung volume reduction surgery may be somewhat less effective. Alpha-1 antitrypsin deficiency emphysema is a common indication for lung transplant, a common reason people have transplants. These people may have some increase in short-term complications, but long-term survival seems at least as good as that of other patients, and maybe better. Lung transplant improves lung function and quality of life, but it is not proven to extend average survival in patients with emphysema, although we hope and think that if we select people appropriately, it will. And of course, lung transplant is very expensive. It places huge demands on the recipients and their families, and there are many potential complications. So thank you very much, and I'm happy to answer questions, or I guess after.
Yes.
Okay, thanks.
Thank you.